So starting a little bit from the market itself, if you look over on the left-hand side, a lot of what's happening especially in the post-acute care space, because of the audience that it serves, is being driven by Medicare and Medicaid policy from CMS. And so there has been an increasing pressure over the years to move away from a fee-for-service model, which is what you're seeing on the top here, all the way down to more of a population-based payment model. Seema Verma, before she left office, said very clearly that CMS is trying to get out of the fee-for-service business. That was reiterated by Brad Smith of CMMI on a call we were on not too long ago. But certainly fee-for-service is where we have been. And so if we look at sort of the track record of how our health system has been tracking over the years, you'll see the obvious rootedness in fee-for-service models. And then over time, we're starting to see some of those models add quality and value to the contracting around reimbursement in the form of bonuses and things like that. PDGM, PDPM coming into the post-acute space, starting to assess the value of the services that are being driven. And by value, it's a combination of cost and quality together, equaling value. And what I think starts to get really interesting is when you look at where the ACA pushed us into these advanced payment models that were built on top of the fee-for-service model that we have in place today, you start to see other groups getting a lot of pressure from CMS to shift how they do their business and how they're serving the cost and quality of CMS overall. And you'll see that that's where we start to see our risk-bearing entities. So those advanced payment models, those APMs, including things like ACOs and the new models of DCEs, start to come into play here. And then on the sort of farthest end of the extreme with population-based payment, the place where CMS wants to end up, we're starting to see more and more activity there, specifically on the physician group and the health system side. That's where they went after first. But as you notice by the MA Carve and some of the quality programs that are coming, those population-based payment models are starting to be enacted. And specifically when we talk about, obviously MA plans have been capitated for a while, but DCEs, direct contracting entities, have a global payment, global capitation option to them. And if those DCEs are under the global payment model, all of the services that a member, a beneficiary gets will be included in that capitation. And that's when it starts to get really interesting for our post-acute friends, right? And so we're going to continue to see that trend. We're going to keep seeing that downward pressure pushing people into these global capitations. And what that will do is put pressure on our post-acute system to start thinking about how it delivers care and probably change some of the ways that it's working, such as happened with the physician groups and the health systems earlier in the 2010s as they started to look at some of these models.